Hello everyone, and a very warm welcome to this PASCAL Precision simulation showcase. This is a session sponsored by Edwards Life Sciences. My name's Sam Dawkins, and I'm joined by Federico DeMarco. What we're going to do in the next 90 minutes is take you through three key learning objectives. So the first learning objective is to understand the differentiating features of the PASCAL Precision system. The second is to appreciate some of the safety features that allow us to tackle a complex range of anatomy. And the third aspect is to understand how the differentiators of the PASCAL Precision system can allow us to treat patients with mitral and tricuspid regurgitation with confidence. Now, I know that you came to our session in London Valves, and you will know that what we try and do in these sessions is take some of the most experienced operators in the world, and they're all behind me now, and put that together with the might of the Edwards team, who have put together some really impressive simulators. And while it's all set up here and all looks very calm and under control, I thought I might just share with you the amount of work that goes into putting this kind of thing together. So here's a time lapse of all the very hard work that went into putting this together yesterday. So a huge amount of effort to put together multiple different simulators demonstrating multiple different technologies with some of the most advanced simulation capability that is available. So the discussants today who will be going through each of the facets we'd like to look at are Maurizio Taramasso, Didier Ceche, David Azamendi, Christian Besler, Yiling Heng, Amir Mahabadi, Niklas Schofer, and Jörg Hausschleiter. Now, Federico, we want this to be an interactive session, is that right?
Absolutely. Interaction is really important for the success of this session. There are a couple of ways that you can interact with us. The traditional and classic way of standing up and going to one of the 4 mics that we have in the room, or you can type your questions into your laptop, your phone, and they're going to appear here, and then we're going to answer and assess all of your comments and questions.
Fantastic. So keep the questions coming in, and we'll address them as we go through the session. So we've split into 3 parts. We're going to look at atraumatic clasping, we're going to look at predictability, and we're going to look at versatility. So to start with atraumatic clasping, we're going to start with Didier, Christian, and Maurizio with a clinical case.
Okay, I have to say that I'm really excited, in fact, and I'm glad that you invited me to be part of this session. So many work, and I'm sure that we are going to learn a lot all together today. So let me start with a case, if I can find here it is. Just to set the scene and to showcase what we've learned from our daily practice. So this is a patient that we treated a couple of months ago. The regular patient that is indicated, at least in France, a patient at high risk for surgery, 81 years old male, highly symptomatic with an ER class 3 dyspnea. A past history integrating paroxysmal atrial fibrillation, colonic cancer, pulmonary embolism, so quite a frail patient, as it is reflected by the degree of the renal failure with a creatinine clearance that is below 40 milliliters per minute, high pro-BNP level. And if you focus on the bottom right part of the slide, you can clearly understand from the transthoracic echo that this is a patient who has been symptomatic because of high and severe mitral regurgitation with a primary MR, a large EuroA, and a very important regurgitant volume, 85 milliliters. Preserved LV function, but high systolic pulmonary arterial pressure, and the right ventricular function was normal. So here is the baseline echo. It might seem at first look that this is not a massive regurgitation, but the patient was symptomatic with a normal LVEF. And if you have a close look, this is a diffuse mitral regurgitation, a quite eccentric jet with multiple locations. And if we have a close look at the PSI, we can see how important is the EuroA and the regurgitant volume. So this was classified as a severe. If we focus on the left part of the slide, we can identify the mechanism, primary mitral regurgitation with that P2 to extending to P3 prolapse with a very deep flail, a large gap, something that is going to be technically not as easy as one could expect. So this is a 3D view, and you can see the prolapse with the flail and the ruptured chordae, and some kind of remodeling of the disease of the leaflet. So maybe not a very easy case. So the baseline transvaginal echo summary is depicted in that slide, and based on the location, we assume that we would be able to treat the patient with a PASCAL ACE device, maybe starting from the A3, P3 region, and then moving with a second PASCAL systematically to tackle the mechanism more towards the central position. So as usual, we start with a very high position for the transeptal puncture for 4.5 centimeters, making sure that with the point of flexion was going to be parallel to the mitral annulus, but this is something that we are going to be used more and more often as the more we're going to use the PASCAL Precision system. And the first grasping, as started to tell you, was in the A3, P3 region to make sure that we would be able to tackle the entire mechanism. So it's easy to start if you think that you're going to use two ACE devices, two PASCAL devices, to start from the most commissural one and then to move a little bit more central. So this is the result after the first PASCAL, the first capture. And we then went for a second one, more central, but we weren't too satisfied about the results. So it took us two additional attempts, just to find the perfect spot, the perfect location to, at the same time, control the mechanism and get rid of the regurgitation. So we had to move slightly more lateral as compared to the first two attempts with the second PASCAL ACE device. And we did a kind of slightly greater separation of the devices just to obtain a mild regurgitation at the end. So 3 attempts, 3 captures for this patient. So this is the final echo with a mild mitral regurgitation, a slight improvement in the LVEF that was 55% at baseline, and then immediately after the treatment, you can see that the systolic pulmonary arterial pressure went down, telling us that it was necessary to treat the mitral regurgitation. What we learned from this case is that we can do with this device multiple attempts. Maybe it's a little bit more gentle for the leaflets. We're going to experience that and learn more with the data. But so what do we know from the literature about the effect of multiple leaflet capture on leaflet integrity? Thank you for your attention.
Thanks very much, Didier. A great case there, and I think reflective of what we see in the real world. It's not all about nice focal A2, P2 pathology with a discrete jet. This was much more complex than that, and a perfect result. So congratulations for that. I think that illustrated sometimes that there is a need to do multiple grasps, and Christian is going to tell us a little bit about some of the data behind that and the safety of that.
Certainly. Thank you, Sam. Dear colleagues, certain features of the PASCAL system, such as the nitinol construct or the specific configuration of the pedals or the retention elements, have been suggested to mediate an atraumatic leaflet capture during a mitral or tricuspid edge-to-edge repair. And although all of us have their own experience with or clinical impression on the performance of the PASCAL system, the effect of multiple clasp attempts on leaflet integrity is currently unknown. And actually, we lack a standardized model to assess this effect in a systematic fashion. And that's why Edwards Life Sciences partnered with the CVPath Institute to really evaluate the impact of multiple clasping and closing attempts in more detail during mitral and tricuspid valve procedures and to assess the effect on leaflet integrity. So they were using hard cadaver models as depicted on this slide. And the left and the right atrium were excised to have a direct view and a direct access to the mitral and tricuspid valve. Both valves were actually sectioned into a control site and an experimental site, and I'll explain you in a minute what that means. and the left and the right ventricle were connected to a pump tube that allows continuous forward flow into the left ventricle to expand the ventricles, to stretch the leaflets, and to prevent folded leaflet capture during the clasp and closure trials later on. So, as mentioned, each leaflet or each valve, the mitral and tricuspid valve, was partitioned into two sides, a control side and an experimental side. On the control sides, 2 leaflet capture and closures were performed, and on the experimental side, 15 leaflet captures and closures were performed. Both implants were tested, the PASCAL P10 and the PASCAL P5 or ACE, both on the mitral and the tricuspid valve, with a number of experiments ranging from 3 to 6 to systematically address and quantify the effect on leaflet integrity. 2 scoring systems were established. One score that assessed for leaflet damage ranging from a score 0 to a score 5, with a score of 0 corresponding to no discernible leaflet damage, and a score 5 corresponding to a more than 5 millimeter measuring surface defect on the valve leaflet, and a second score that assessed the extent of surface roughening ranging from a score of 0 to a score of 4. Score 0 corresponding to no roughening, 1 minimal irregularity, grade 2 minor imprints, grade 3 deep imprints, and grade 4 surface tears visible on the leaflet surface. A leaflet damage score of equal to 4 or higher than 4 was considered and predefined as a clinically relevant leaflet injury during clasp and closure attempts. These are representative gross images that actually depict the experimental setup. You can see digital photographies of the excised leaflets immediately after completion of leaflet captures, and you can appreciate that this model is apparently suited to assess the effect on leaflet integrity, because you can see spots where you can see the impact of the device on the leaflet surface, both on the mitral and the tricuspid valve, as shown on these digital photographies. So what about the findings? What were the results? First, and importantly, there were only impacts detectable on the atrial side of the valve. So there was no impact detected on a digital photography on the ventricular side of the valve. And there was almost no leaflet damage or leaflet injury and surface roughening on the control side after 2 leaflet capture and closures. There was indeed a larger extent of leaflet surface imprints and leaflet surface roughening on the experimental side after 15 leaflet clasps and closure, but it remained below the predefined threshold for a clinically relevant leaflet injury, both on the mitral and the tricuspid valve. These are combined data for the PASCAL P10 and the PASCAL ACE or P5. What about a more detailed look at the implants themselves? So what about when we have a separate look at the P10 and the P5 experiments? The image and the data were more or less the same, so there were no significant differences between the impact of a P10 or P5 on gross leaflet damage or surface roughening, both on the mitral and the tricuspid valve. Certainly, such kind of experimental setup has limitations. It's a stable, static system without the dynamic motion of the heart and the valves throughout the cardiac cycle. There were no physiological pressures in this model within the ventricles, and this may all lead to an underestimation of a leaflet injury in this ex vivo model. On the other side, it is a human cadaver model that's prone to autolysis and probably more tissue fragility, which may also exaggerate the leaflet tissue damage that was observed at the end. What we can conclude is that there are small surface imprints and minor damages only on the atrial side of the leaflet, both on the control side, so after very limited amount of clasp and closure, and also after very extensive clasp and closure process with 15 attempts. This holds true for the mitral and the tricuspid valve, and for both implants, the P10 and the P5. So overall, this in vitro or ex vivo study showed no clinically relevant leaflet injury, even under extreme clasping and closing experimental conditions. Thank you very much, and I'm happy to have a discussion with you on this data.
Thanks very much, Christian.
Yeah, thanks. I think this is really reassuring, the fact that we can really do multiple attempts in grasping with minimal leaflet damage, and also this translates into clinical practice in the sense that we should not be afraid to reposition our device multiple times in order to achieve a perfect result. We have a question for the audience. We have a few minutes for discussion before going to Maurizio's simulation. Maybe this is for Didier. When treating a mitral valve flave, do you think using more than one device is mandatory, and why PASCAL ACE instead, I suppose, of P10 in degenerative anatomies?
That's a very important question. It tells us about the experience, the amount of experience that is presented within the room. I have to say that this is a key issue when you are tackling a primary MR with a large prolapse. Tackling the mechanism is mandatory. It's of major importance because we have the immediate result, but what we want to make sure is that we have a sustained result, sustainable results. So most of the time we use at least two devices, two PASCAL devices. And why the PASCAL ACE is just because of the ability to capture more leaflets and to make sure that you secure the capture that you get. You treat the mechanism, and then you have a little bit more of attention on the leaflets to make sure that the results is going to be sustained. So that's my general philosophy for this type of primary MR.
Thanks very much, Didier. And a great question, and keep them coming. We can see them popping up on the screen, and we'll go through them as we go through our session. Now that we've got started, I thought it might be helpful just to get an idea of the experience in the room, because I know that we will have some very experienced operators, and we'll have some less experienced people, and we'll also have people who haven't used the system before. So firstly, could you put your hand up, and this, whether you're an imaging expert, whether you're an interventional cardiologist, whether you're a surgeon, put your hand up if you have been involved in any TEER procedure ever. Okay, so that's most people. Put your hand up for me if you have ever used the PASCAL system in any valve. Okay, so a smaller group. And now, could you tell me if you have done more than 10 PASCAL mitral procedures? Okay, and put your hand up if you've done more than 10 PASCAL tricuspid procedures. Very good. Okay, so we've got a wide range of experience. We've got a lot that we'd like to share with you during this session. So you've seen one aspect, and it's a complex problem, isn't it? On the one hand, we want the device to be completely secure. We don't want surprises later. We don't want single leaflet detachments. But on the other hand, as in Didier's case, it is not that uncommon that we have to do multiple grafts. And in that case, we don't want trauma. We don't want to be damaging the leaflets if we're doing multiple grafts. And Maurizio is going to take this story on and tell us a little bit more.
Yeah, thank you so much, Sam. And yes, I'm going to through a few slides to show some quantification of this, how atraumatic PASCAL is and how important it is to keep the leaflet inside after the clasping. And then we are going to test on the simulator to show live actually how we can measure this. We've been discussing a lot about atraumacity. We know that the 19-hole configuration of the PASCAL is extremely elastic, is extremely respectful of the anatomy. When we talk about atraumaticity and force of closing, we have to distinguish between the so-called clasp force, which is the one that retains the leaflet after the capture. We want to have atraumatic force to capture the leaflet, but we want to have enough retention, so we don't want to lose the leaflet if we eventually perform independent clasping or optimization, so we need to have firm retention of the leaflet without damaging it. On the other hand, we have then the closure force, which is the so-called pedal force, when we close the device. And in that case, we want to have a uniformly distributed force that doesn't damage the leaflet and the surrounding structure. That's why we have to test both, and we are going to measure both. This has been done on several attempts on the simulator. Both of these forces are passive, and this is really ensuring that it is extremely progressive and not traumatic. This has been tested on this in vitro simulator by the company, by Edwards, where actually both clasping and closing force have been measured, quantified. You see the simulator that we are going to test later on. Both PASCAL ACE and PASCAL P10 have been tested several times. It is quite easy, it is quite intuitive. There is a simulated leaflet, there is a simulated valve, there is a membrane with a sensor which has the same thickness of the mitral leaflet, which is about 1.5 millimeter. I think there is even a demo circulating in the audience, so you can really feel it how it is. And this sensor between the two silicone membrane can measure the clasping and the closure force in terms of Newton. Actually, first of all, the clasp force, so which is the force that is retaining the leaflet when we drop the clasp during the capture. You see immediately what I mean with clasping and what we are going to test in a few minutes. So when we drop the clasp, you see that the green line is going up, and then it stays constant. So we have constant retaining force over the leaflet. This is a PASCAL ACE. And this is what we are going to see in the quantification. This is the sensor on the membrane. And you see actually that the observed force, the clasp force, is concentrated at the level of the retaining element. And it is constant. So this is the PASCAL P10 and this is the PASCAL ACE. There is no significant difference in these 15 attempts. So both are constant, both are atraumatic, but enough to ensure leaflet insertion and not to have any leaflet detachment during Tarzan maneuver or leaflet optimization. And then the second force that we are going to check, which we want to be, in this case, constant, uniform, but extremely atraumatic, because especially in some anatomy and in some difficult situation, we may be afraid of leaflet tearing or leaflet damage, is the paddle force, so the force of closing, which kind of force, which amount of force we are going to apply on the leaflet when we close. Obviously, we should be careful to release the tension and to do it carefully, but the feature of the device, the passive closure and the nitinol features of the device are extremely important. And here you see, this is the closing force, this is another ACE, and this is the force that we are going to measuring during the closure. You see that the green line goes up again, up to 1.5, and then stay constant and stable. And this is the closing force. And this is what we are going to see in the testing, so on the sensor. The closing force is distributed across the paddle on the surface between the paddle and the leaflet and the retention element without any other area of pressure concentration. So it's really uniform and there are no different area where the force is located. It's really concentrated only where the paddle and the clasp are in contact with the leaflet. Again, with no difference between PASCAL P10 and PASCAL ACE. So obviously there are some limitations in this simulation. It is not moving, it is static. The tissue is slightly different, the quality, but still, it is extremely intuitive and it's extremely convincing because we can measure it, we can quantify. And even if it is a simplification that may eventually have been underestimated the reality, it gives us extremely important insight on how atraumatic is the closing of the device, and on the other hand, how we can have stable retention mediated by the single retention element that allows us to keep the leaflet in position during eventual leaflet optimization. And I think the best is probably just to quickly check it on the simulator.
Maurizio, I don't know if you want to tell us what you have on the simulator and what kind of transducers and what are you going to actually show.
Exactly. I think if we can show it on the big screen, we are going to see exactly what was present exactly also during the slide. The black square is actually the sensor on the leaflet. So we are going to drop the clasp on the leaflet, and we are going to see in this black square, especially in the green subsection of the black square, which is actually the surface of the leaflet where the clasp is in contact with the sensor, the force of clasping first when we drop the clasp. And in the white screen, in the white graph, we see the force in Newton in the vertical axis and the time. So we are going to see the amount of force that we apply during clasping, dropping first, and then during the closure over the time. So how fast the force goes up, and then how it stays stable during this time in seconds. And obviously you have a camera on the simulator. We have the PASCAL. This is a PASCAL Ace already in position, which is actually already ready to drop the clasp and capture the leaflet. From one side, so this is a kind of simulated intercommissural view, and below you have a kind of 3D surgical view. So we are looking the device and the valve from above, from the atrium. So I think I don't want to mess up with the system, but what we have to do, we have just everything is ready. We don't need to do any maneuver. We have to drop the clasp and look what happened. So clasp down. So the clasp are down, and you see the green line goes up to 0.5 Newton and then stays stable. And in the sensor, you see the red is the maximum point of where the force is measured, which is corresponding to the retention element, which is extremely stable over the time. So this is ensuring that if we do independent leaflet capture or leaflet optimization, the leaflet stays in. We don't lose the leaflet if we slightly move it towards the other leaflet. And then we are going to now closing the device, and I'm trying to do what actually we do also in reality, so to release the tension during the closure. I try to do it really slow so that you can appreciate. And I slightly release the tension during the closure. So now the device is closing. And you see that the red is distributed in the surface where the leaflet is inside the paddle and the clasp. So there are no other portion on the leaflet where there is tension or force applied. And it is extremely stable over the time. So it goes up, and then it stays stable without any non-uniform distribution. So it is stable, it is uniform, it is localized where it should be localized. And this should ensure us that we should not damage the leaflet. So we have stable retention, but atraumatic. So the combination of actually what we want to have when we perform this procedure. I don't know if there are any comment or question. I hope it was clear. It's quite intuitive. I mean, I'm not a physician or an engineer, but it's quite intuitive and visual to
Didier. Well, that was a great demonstration. Thank you very much for that.
I have one question, and maybe it's, Jörg, you could answer that as well, because I like to use one slide that I've got from you. It's the Tarzan slide, Tarzan maneuver. So you capture one leaflet, and then you move to the other one. And so how is it gentle? Is it more traumatic to the leaflets based on your experience, or is it a maneuver that can be safely applied in a clinical practice?
I think it can be applied very, very safely in clinical practice. In fact, when I'm looking into my clinical practice on a daily basis, we're using an independent subsequent grasping, I would say in almost 95 to 98% of patients, regardless if it's going to be mitral or tricuspid. And then you can really focus during the clasping process on one side of the device, really make sure that you have a good leaflet capture, and then you swing over to the other leaflet and do the same. Be very focused on this leaflet and capture this very nicely. And this is very safe.
I think that's a really important point, isn't it? Because the independent grasping aspect is good, firstly, for capturing the leaflet, but also if you do it one at a time, you can then focus on the imaging. You know, the imaging can be difficult, and focusing on one paddle at a time actually makes a really big difference to your confidence that you've got a decent grasp.
And there's one additional aspect, because of this maneuvering, swinging from one leaflet to the other, you might get even more leaflet into the device, and your analog plus TEER effect might be significantly higher.
And the positive thing is that you don't miss the leaflet.
Yeah, you focus. You focus on.
So
the
maybe
leaflet.
at the end of the session we can play with that and show that, do the maneuver. We open one of the clasps and just do the turn, and we can measure the forces if they change.
Oh, that's a good idea.
We don't have time, but we can do it at the end.
So one of the things, if you haven't used PASCAL before, or you're early in your experience, what you might notice when you do the procedures is that on fluoroscopy, and you can sometimes see it on echo as well, you can see the device flexing. So you can see it moving slightly. And in my opinion, that's part of the reason why it's so atraumatic. So what we have here is a PASCAL device. So these are silicon leaflets, and this is a PASCAL ACE device closed onto the valve. And hopefully that's appearing on the screen. Yes, it is. And what you can see from this is if you look at it side on, the device can flex but still be secure. So with the heartbeat, you see the device doing that sometimes if there's a lot of tissue. And if you look from underneath, you can see how stable it is. Now, there are some of these dotted around the room. So if you'd like to get your hands on, do, because I think it's important. You know, we see all this on echo all the time. We see it on fluoro all the time. We think it's secure, we think it's stable, but to have it in your own hands, I think really makes a difference so you understand how it works. Now, I think I'll let you have a look, Didier. There you go. So you all came here for the CME. I wasn't expecting it to be physics, so thank you for bringing the physics to EuroPCR. Thank you very much for that. So we've covered the first part of what we were hoping to do today, which is to look at the atraumatic clasping and closure. And the second part of today is to get on to predictability. We'll do that in just a second. Have we got any other questions to cover now, or we can come to them a bit later?
I think we can come to them later.
Perfect. Okay, so predictability is the next part, and obviously a very important feature for all of us. What we want is to get our grasp, and for what we get at the time of grasp to stay. We don't want to have any surprises. So Amir Mahabadi is going to give us some data on that.
Yeah, thank you for the kind introductions. My pleasure being here today. The audience is packed, so that's a good sign. I'm going to talk about predictability of what happens if we release a device from the valve, and everybody who's doing the implants in daily routine knows that, especially in a small valve, if you have a good result after grasping and you close the device and then you release it from the system, and the residual MR reoccurs, that these cases are frustrating and challenging for the whole team, and sometimes even suboptimal results are then optimal left for the patient. And in the past, we've done an analysis comparing the mitral clip system to the PASCAL system on the first generation as a single center study, and we've compared how the residual MR, so how the MR changes prior to post-release of the system, and whether we see any changes. And what we've seen in the end is that for the mitral clip system, there was some deterioration of the MR, of the residual MR, while we saw that significantly less frequent for the PASCAL system. So this was single center and first generation, and I would like to share with you today the interim analysis for a new study that we are doing on the precision system of the PASCAL system in a multi-center setting. So this is a retrospective study where several centers do acquire standardized imaging of the residual MR prior and post-release of the system. And these images are sent to a central core lab, and we evaluate here at the central core lab then the residual MR prior and post-release and compare that images. So just for this interim analysis that I'm sharing today with you, we included 141 patients in total. Mean age was 78 years, and STS score was 5.5. On average, there were 1.4 implants per procedure, and at least one complexity criteria was found in approximately half of the patients. 40% of the patients had DMR, 40% approximately had FMR, and mixed pathologies were found in 20% of the cases approximately. All of the patients, not surprisingly, had moderate to severe or severe MR at baseline, and at discharge we achieved no or mild MR in nearly 80% of the patients in this cohort. And if we look at the changes of MR during the release of the procedure, so how does the MR change when we release the device from the system, we observed that in 94% of the patients, we had really stable MR there was no deterioration of the MR, and even in 23% of the patients, so nearly 1 in 4, we observed an improvement in the residual MR after release. Looking at different etiologies of MR, we saw the best results for the DMR cases, slightly less impressive results for mixed cases, still nearly 90%, and it's limited to the low numbers of cases in this group as well, which we have to disclose. I would like to continue with the case of a 77-year-old male patient presenting with dyspnea near stage 3. He'd undergone open heart surgery approximately 10 years ago with aortic valve replacement, bypass surgery, and also ascending aorta replacement. This is a transthoracic echo prior to the implant. You can appreciate that left ventricular function was at least normal to maybe even a little bit hyperdynamic. LA was enlarged, and we see this really massive mitral regurgitation due to a degenerative problem of the posterior leaflet. This was also confirmed in right heart catheterization with markedly elevated V wave. And this is the 3D TOE pre-planning for the procedure. We like to measure both the length of the leaflets prior to implant and also the width of the device. And here we see that we had approximately 12 millimeters length of the posterior leaflet, so it's long enough for any device. And the width of the pathology was 18 millimeters, so we decided as a plan for the procedure for a 2-device strategy with 2 ACE devices. Going into the procedure, the first attempt was to close the MR to the medial side. The aortic valve in this projection is as our house standard on the bottom side of the image. So the anterior leaflet is also bottom and the posterior is on the upper half. And we closed the MR to the medial side, had then the remaining MR on the lateral side, and this was very stable, so the medium MR didn't reoccur after release of the project. We then placed a second device laterally over there, released that device, and again we had a very stable result with no residual MR after the implant of these 2 devices. The gradient afterwards was, in median gradient, was 2 millimeters mercury, and the procedure itself took us 52 minutes. Guide sheet in to out time was 38 minutes. Fair fluoroscopy time. We do all our edge-to-edge cases in conscious sedation, so no intubation for the patient, and the patient was discharged on the second postoperative day. What is really one of the key messages, or also the first analysis told us, that if we have this stable and predictable results during the procedures, that these good results also stay for long-term follow-up. This is 3 months follow-up of this patient. We see practically only trace MR also at 3 months. No gradient increase. The patient improved dramatically, also clinically, and also with NT-proBNP values over time. So in conclusion, this is a retrospective multi-center cohort study with central core lab evaluation. We have nearly 80% mild or no MR at discharge in a real-world setting, and we have really, really excellent predictability of what we achieve prior to post release of the implant. And we even see improvement in residual MR in a fair amount of cases from pre to post delivery. Thank you.
Thank you, Amir. Great presentation. Let's start the discussion maybe with a question from the audience. Why for this case? It's a bit of a general question about strategy, but I think it's interesting. Why for this case did you choose an ACE or 2 ACEs instead of a P10? Classic question, but I think it can be important.
The main idea for as I've shown, the length of the leaflet is definitely a topic. So if we have shorter leaflets, we might go either for a P10. And for the DMR cases, even with the big prolapses or flails, as in this case, we want to capture as much of the leaflet as possible, get it as deep in as possible to get a good result, and that's why we decided for the ACE in this case, and 2 devices just because the width was so big that we were pretty sure that we couldn't cover all this defect with just 1 device. So that was the idea for 2 devices and for the 2 ACEs here.
So as a general guidance, ACE for degenerative is the way to go, because we could say that for a larger grasping, a P10 could be okay.
That's true as well. I wouldn't say for all cases, but for the vast majority, yes, I would go for an ACE for the DMR cases. Yeah.
Okay.
But when we go back to the previous session, when we're looking at the forces, we also saw that there's a slight difference between P10 and the ACE. So ACE has a little bit stronger forces, and especially probably in the degenerative disease, this additional forces might be of interest or help to get a better leaflet grasping, a better annuloplasty effect, and perhaps by that also better durability.
Maybe one other thing that also let us think more towards an ACE device is that it was not a 100% A2P2 commissure, but we had to go a little bit to the lateral commissure as well, and there we have to deal with some cords as well, and for that cases we also tend to select an ACE more frequently. Yeah.
Great, thank you for that. I mean, I think these are really important points, a kind of algorithm to have for which device to use. And there's variability amongst different operators, but broadly speaking, if there's too much tissue, I think most people would go for ACE. If there's too little tissue, such as FMR, particularly atrial functional, where everything is very stretched, then P10 might be a better option because it's got a spacer, so there's less tension on leaflets that are already very restricted. And then another consideration is if you're in a situation where there's lots of cords, such as commissural mitral or in the tricuspid position, then ACE may be a better option. So we have another simulator coming up, so David's going to get set up.
I think Amir raised a really interesting data that it's mainly something that most of the operators felt, that it's once you release the PASCAL, the results sometimes gets even better. And we try to understand why this happened, and probably the simulator will help a little bit. Okay, so this is a special simulator. I don't know if it has the name, or we can call it a Physiologic simulator. As you can see, it's not the typical simulator with a big heart. In this case, you can see that there is some sort of a real ventricle heart beating, and we have papillary muscles and chordae, and we can control all these part of the mitral apparatus. So with that, what we get, we are able to simulate or emulate any sort of mitral regurgitation etiology. So we can simulate functional mitral regurgitation. We can simulate a prolapse. So this allows us to see how the device behaves with this simulator. So for this particular case, we have simulated a functional mitral regurgitation, and since the valve area is a bit small, and since it's functional, and really a super fan of P10, so we're going to do this case with P10. And the aim is to show you why at the end you don't have surprises or bad surprises when you release the device. And probably it has to do that, as you know, PASCAL has 3 catheter system, and for this reason probably there is part of the tension that is divided and the device doesn't get the whole tension. And for that reason, at the end, once you release, that release of the device is really soft, and for that probably you don't have a worse outcome once you finish the procedure. So let's start with that. So. Unfortunately, I don't have the ROLA references that we use in human, but we'll
no pressure, David.
No,
we know it's easier in
that's right. But I can check that I'm doing a nice job for the moment. So the first thing is I'm flexing the flexible catheter, and the aim here is just to have a straight trajectory through the valves and have the device fully open. And when it's fully open, we aim to have the leaflets at the same angle that we have of the device. So I'm almost over the valve, as you can see, and I'm opening the paddles. So here, the first thing that we'll do is we'll check with the echo, we'll check the clocking Fortunately, I've been lucky, and just opening it, I'm almost.
That's skill. That's not luck.
It's how they prepare it. This is another part, important part of the device. So once we are there, what we normally do is you can do it. There is different strategies, but you can do it with the device fully closed. I normally do it opened, but you do a slight trajectory to see if the angle it looks good. And for the moment, it looks pretty good. Maybe it goes a little bit from, if you check in the camera, it's going a little bit from medial to lateral. It doesn't look a bad angle. Probably in this case, what we'll do is we give some more flex.
So the top, just to orient you if it's
That's
the
right.
unusual view, the top left is bicommissural, so that's a kind of 60-degree TOE view. Bottom is AP, isn't it?
That's
It's a
right.
135 LVOT view.
What I did is I flexed a little bit and I advanced the whole system to go a bit more lateral because we want to go to do a grasping in A2, P2. Okay? So now I'm a bit posterior, I give some anterior rotation, and I go for the perfect clocking. Just as you can see, there is one-to-one answer with the catheter, so I'm perfectly aligned. So if you do agree, and if you check, I think it is at this point, the echo helps, but probably if the direct video helps a little bit better, you can see my catheter, and you can see that the trajectory is really straight at this moment. So, because as I said, the valve is small, in this case, to go through, I will need to close the device.
So there are lots of differences with this aspect. Some people cross open, some people cross closed.
Yeah.
Pretty much everyone crosses closed just for second devices.
Yeah,
I personally always cross closed just because you sort of don't interact with cords.
Yeah, to me, if you go with single device, I prefer to go open because I have the feeling that the device itself pushes the cord out, so you don't get entangled. If you go close and you open below, you can get entangled because you're going through the cord. So if the device is open, my feeling is that you don't get entangled. So as you can see, I'm going a bit medial. So the good thing of the device is it answers perfectly. So at this moment I'm going to take some of the flex, and
one thing I like, and it's important to notice how to accommodate clocking and rotations on the device. You act on two catheters, and you give a compensation on the other catheter. This is an important point in handling the device. Look at his hands. He's acting on both catheters simultaneously.
And what you sometimes see when people are learning is that they over-torque it, and then it gets to where it needs to be, but then it continues to rotate. So what you're seeing with David here is he's going to just beyond where he needs to be and then coming back a bit, and it stops the device continuing.
That's right. Indeed, we have a maneuver that is if you push a little bit the leaflet, and if you do an advanced retreat maneuver, when you push the leaflet, they come quickly fast back, so that you got them all over the paddles already. So that's where we normally do. But in this case, I said the valve is small, so I went with the device closed. I lost some of my alignation, so I'm doing the counterclockwise movement, and I'm pretty good aligned now. So if you check in the echo, I'm pulling back slowly. Probably I need some posterior rotation here, but it looks that the leaflets are almost there. Can you show me in the echo? Eva, it's a difficult. I know the echo window. It's not the best one, but we're getting a good one now.
But look at what happens on camera. We see already the posterior leaflet, which is kind of staying still on the.
And the thing is that you don't need to rush. I mean, I'm with my hands up. I leave just the leaflet just positioning there. And indeed, if I have any doubt, what I can do is I go down with the clasps, so they can recheck, and while they recheck, you can even see sometimes the clasp going up and down. So this is an indirect sign that you have a capture of the leaflets. It's difficult to check now, but I think my feeling is that both of the leaflets are inside. So what we'll do is we're going to fully close the device. Do you think, Eva, we can put some color there?
So Eva is doing the echo here, and I think there should be an honourable mention, because not only is she doing the echo, she's one of the Edwards engineers, she also dabbles in mitral valve surgery. So she made this valve,
That's right.
which I think is pretty impressive. So this valve can be degenerative, it can be functional, and you can change the sizes of it. So it's an amazing piece of technology.
So what we wanted to show is, if you see the alignation of the catheters, we're pre-aligned with the device. So what sometimes happens, and that might explain why we have a better result at the end, is that sometimes we have an overflexion of the sheath, and the catheters are not fully aligned. So in these cases, you have some residual regurgitation to one of the sides of the device. So that's why when you release it, at the end, the device turns to the natural position and you have a better result. But you can get that before you release the device. If you realize here, I'm gonna overturn a little bit more, okay? The two catheters are not aligned. So at this moment, if you see that they're not aligned, you try to correct that. You take out the flex back.
So what we're looking at is the left-hand boroscope view up there. Do you see how you can see the implant catheter is against the outer curve there?
That's right.
It's because it's overflexed.
That's right.
Which you would try and avoid in real life,
That's
but if
right.
you spot it, you can correct it.
That's right. But sometimes for the clasping, you overflex a little bit because it's the best position.
Yeah.
But after that, you have to remember that you can release this tension. So here, I'm going to just relax that. And once relaxing that, what will happen is, since I'm taking out the flex, since I'm taking out the medial movement, at the end, I will need to, so all the system will go a bit lateral. So at this point, I need to remove the whole system back a little bit, and I'm completely aligned, and I have the 3 catheters on the line. So now, I'm sure that the result that I'm having in the echo is going to be the final result once I release the device. So we can check it. You want to do the honors?
I'm a bit nervous.
Yeah, give me a hand.
So one thing to say, which is quite a neat feature, particularly useful in the tricuspid position, is that when you're doing the release, if there's one leaflet where the imaging is particularly difficult or the leaflet is particularly restricted, take that suture out first, because then you can see for sure that the leaflet is in. And this is pretty unusual, but if the leaflet were to come out, you can then get the device out without having an SLDA. So take out the suture of the leaflet you're less comfortable with. Now, in the mitral position, you generally have very good imaging and very good grasping, but sometimes in the tricuspid it can be difficult. So what I'm doing is fixing the implant handle with my left hand, because you don't want to unintentionally pull that. You can also close here, as David has done, just to make sure that I don't mess up his good work.
Now we'll release it, so you don't have any tension.
So that is 2 sutures out. Am I allowed to release this, by the way? I'm not going to get into trouble for doing this. Okay, so all you're doing is turning it, and then coming back a tiny bit, turning it. Feels very strange doing it without gloves.
Yeah, that's
Feels
right.
very odd.
Flat fluoro, right? You can have the sign from the fluoro to know if you're in there. There you are. I'm going to pull back a little bit.
We are
there
off.
You are.
Very good.
See? There you are back. So you see in the echo, it was difficult to see the color, but there is no change in the color. And that's what I mean. At the end, the 3 catheter system, what it does is that the shaft that is holding the device is not so tight. So it doesn't improve your result. It leaves the device freely, and you know that this is going to be the ending result. So once you release it, you don't have any surprise. And if you have a surprise, it's for good. And the reason was that you were probably overflexed and you didn't release that tension. I don't know if I made myself clear. I tried to.
You perfectly clear.
A great job.
That was great. I also did a good job, I thought.
Yeah. That was the easy part. We have still a couple of more technical questions. I think this is what the audience is interested of, and here we have the best of the best, so we're going to find the perfect answer. Do you routinely try to close the clasps in systole or in diastole? Does it matter?
If you ask me, I don't. To me, I mean, there are some occasions that you have to approve and take advantage of the movement. But in most of the cases, the way we work is we try to keep the leaflets stable over the device, and after that we go down with both of the nodes together. At least the first time. And if you have difficulties to grasp one of the leaflets, probably you already can think in individual grasping. We do it. Probably we do the individual clasping most on the tricuspid cases, as Dr. Hausleiter said, that to us it's really important to have a lot of leaflet there. In the mitral, we really try to have at least have a chance to have a simultaneous clasping. And if you are not able to do that, because my feeling is that in the mitral sometimes when you do the rotation and you lose sometimes the alignation, the perfect alignation of the device. And I think in the mitral it's really important to be completely aligned, because in our case, our aim is trying to get the best result with a single device.
So we can say that it doesn't really matter
Not to me.
if it's systole or diastole. What matters is to attempt a simultaneous in order to keep that perfect alignment.
But I think you'll find lots of variability with operators with that. There are a lot of operators who only independently grasp, and I think we all have different views on that. And I think mostly you shouldn't be trying to time the grasp, because if you are, you probably don't have enough leaflet. The time where you do sometimes need to time the grasp, I suppose, is in the tricuspid position, particularly on the septal side. You know, the leaflet can be a bit restricted, and then timing it with the cardiac cycle can be helpful.
May I add one point? I'm pretty impressed by the predictability of the result, and that's what we all want. You are during the procedure, and you need to make to take a decision. Do we release the PASCAL or not, or do we move to another location? We talk about the regurgitation, but what about the mean gradient? Because that's a very difficult part of the procedure, because we know with the over device that sometimes you get a big gradient, because a high gradient, because there's a lot of tension in the system. You are pulling a lot or distorting a lot the anatomy. What is your experience, David, about the gradient? Is it stable before and after release, or have you seen slight changes?
Yeah, normally when before the device is released is the final gradient you will have the next day with the TT.
It doesn't move.
So what happens is normally when you release it goes a point down, and after that the next day on the TT you have this point up. And the gradient discussion, to me, something that we need to clear is what happens with P10, because sometimes when you have a small valves, we still don't have clear if it's better going with a thinner device like a ACE, and some will justify that it's thinner, so you can have a lower gradient. But some others, we are prone that we say that the P10 has a lower gradient because you don't grasp so many tissues, so you don't push so hard of the valve. ACE is really strong, and you really can increase a lot of the gradient. My feeling with the P10 is that it just hold the leaflets and fills the gaps with a spacer. So you are able to probably control a little bit more the gradient. So that's probably the key question. I don't think for normal valves the gradient is an issue. I mean, it's weird that in a normal valve you have a significant gradient, but it's true in those patients that you are with valves below 4 is something that you have to take into consideration. At least you have to have the planning that you have to do with a single device the best you can. And that's probably one of the advantages of PASCAL, that you can do several attempts to get the perfect result.
Well, that again brings up the predictability angle. Say you have a smallish valve and you know you can only use one device, and you've got a good result and an acceptable gradient. If you release and it changes for the worse, that's a real problem.
That's right.
And that's one of the advantages
you have to play
of
with
this
second
system.
device. That's a problem.
Because what you see is what you get generally. So I think we've seen some simulators, we've talked through some data. Now to the real world. Jörg Hausleiter is going to give us some real world data.
Yes, thank you very much. We have seen quite a few things about physics and these models, and now we talk a little bit perhaps beyond cases, what we are going to really experience in clinical practice. And it's my pleasure to be here. And I'm going to share with you some data, not only related to the Edwards system, but overall what we are seeing in Europe at the current time, mainly focusing now on tricuspid disease, because up to now we have mainly discussed mitral. So the EuroTR registry is a registry which we initiated some years ago, and in the meantime we collected more than 2,000 patients who have been treated for tricuspid disease with an edge-to-edge device, and the patients have also some follow-up. These are the sites who are participating in this trial, and it's still ongoing, and we're still collecting data and doing all different analyses. What we looked at, for example, is how can we predict before the procedure if we're going to get to a TR reduction of moderate or less. And in this analysis, which is very similar to other analyses, we saw that the tenting area and the size of the vena contracta in the biplane assessment is predicting outcomes. So if you have less tenting, smaller vena contracta, then you get some good results, meaning that 92% of patients will end up in a moderate or less TR. When you see all the other yellow, orange, and red zones, when you have a lot of tenting, a very large vena contracta area, then this number drops in terms of moderate to less to somewhere around 65 to 70%. It's nothing very new, and we already knew that if we have a moderate or less result, then it's good. But if you have severe or more, then the survival up to 1 year is impacted. What perhaps is new is that even beyond 1 year, these curves are further diverging. So it's really important that we really get to this moderate or less TR. Then the other question which we ask ourselves is the difference between moderate TR, residual TR, or is it better to get even mild TR? And will this impact survival? And in this registry, we apparently were not able to see a difference in survival between residual TR mild versus moderate. So in terms of that, it might be still reasonable, and that's what we're all targeting, at least, that moderate TR is good. I still think mild is better, and I'm going to show you why. What we are doing also in Munich is we're doing a lot of three-dimensional echocardiograms for quite some time now. And when we're looking at the residual TR, if it's mild, moderate, or severe or more, then this has an impact on the volume unloading, the remodeling, the early remodeling of the right ventricle. And what you do see is the mean values here depicted in blue, that we have an 80% reduction in the end diastolic volume if you get to mild or less TR. It's highly significant. If it's only residual TR of moderate, then it's not as good as mild. It's 10% reduction in the volumes and tended to get significant, but not yet there. And if you have almost no significant reduction in TR, then you also don't see a remodeling. Then there's also a time development of the remodeling process after tricuspid edge-to-edge repair. And I think this is very interesting to see when we're looking at these three-dimensional echoes, and we have now data of more than 230 patients. When you're looking at this time course, so you do see a very rapid drop in the end diastolic volume, while the end systolic volume remains the same in this early first time at the procedure, but also in the first month. So we have a very rapid volume unloading in the first month, while the end systolic volumes remains the same. Afterwards, we have a very significant drop then in the end systolic volume, which is, we think, more a structural than remodeling of the right ventricle. And you see that this goes in parallel then, that the end diastolic volume comes also down. And what you see then over time, that there is this initial drop in the right ventricular ejection fraction, but there is also a recovery of right ventricular ejection fraction over time. So this biphasic reverse remodeling is something which we think is very interesting, and we probably need to talk more about these later effects, because these are only short-term effects of volume unloading and does not reflect the true remodeling process of the right ventricle. There's a lot of discussion about the different phenotypes, atrial secondary TR, ventricular secondary TR, how does it respond to our therapies? Should we treat the ones and the others not? Or how do we perhaps improve the outcomes of the others? And there are, for this differentiation of phenotypes, there are different categories. How do we define those phenotypes? And in the TVAC manuscript, you see that there are a number of factors which will define and help us to define if the patient is more atrial or more non-atrial phenotype. We try to make it more simple. And we are just using two parameters which we think does perhaps reflect best the difference between atrial and non-atrial secondary TR. And this is the ratio of the right atrial size to the right ventricular size. And if this ratio is above 1.5, the atrium is significantly larger, then we're talking about an atrial secondary TR. And the right ventricular function needs to be maintained by the TAPSE. And if you do this ratio analysis in this cohort of 640 patients, you see that around 1/3 of patients have an atrial secondary TR, while the other almost 70% are classified perhaps as some mixed types and ventricular types. And does this have an impact on the outcomes after an edge-to-edge repair? Yes, it does. You see that the patients with an atrial secondary TR have a much higher survival rate, up to 2 years of, here the difference is 66%, or maybe the numbers are not completely correct. But there's a significant difference here in the between the two curves at 2 years. What does it mean? Perhaps we need to have a special look on our patients who have a non-atrial secondary TR, that we're going to get a better result to those, that we better treat them medically, perhaps treat them earlier. I don't know what is the solution, but these patients probably need to have a special focus so that we get to the very similar results as with the atrial secondary TR. And then at the end, I want to show you some data from the European edge-to-edge practice from the PASCAL experience in more than 2,000 patients, data which have been collected by the site clinical specialists. And what is intriguing to see over these 2,000 patients which have been treated over the last year, that the results are extremely good. You see that in terms of TR reduction, we're getting 92% of moderate or less TR at the end of the procedure. And if we're looking even at mild TR, this is a number of 61%, with a very high safety, with almost no events, very, very few acute intraprocedural SLDAs, and the number of devices for the tricuspid side of only 1.8. And this is more or less the final slide, which I'm going to share with you, that Edwards did also an analysis in terms of the morphology. We know that there are different types of morphologies. The more scalps we have, the more complex it's going to get to treat those valves. And the question is, how well is the precision system really performing in these different morphologies? Can we always get to very good results, or should we perhaps reflect upfront which valves we treat and which we should not treat? And if you now see this differentiation here in these 6 bar graphs, you see that for these very first 5 morphology types, you always get to a moderate or less TR grade of above 90%. Only in the very last one, where we have really multiple scallops, multiple atrial scallops, or multiple posterior scallops, then this drops slightly, but we're still above 82%. With a moderate or less TR, and about around 50% for mild TR. So still very good outcome data, even in those patients with very complex valve morphologies. So in summary, as I showed you, the EuroTR registry demonstrates that TR of moderate TR is associated with an increasing survival benefit over time, while the additional benefit of mild TR compared to moderate TR was small or not really visible. Reverse remodeling seems to be a biphasic, has a biphasic component with a volume unloading, which is early, and a more structural remodeling reflected by the end systolic volume over time. Atrial secondary TR is apparent in around 30% and is associated with an improved 2-year survival over non-atrial secondary TR. And again, we probably need to focus a little bit more on this patient cohort, how we improve outcomes. And this commercial experience from Edwards demonstrates that the PASCAL Precision allows for a very efficient TR reduction across this very wide range of tricuspid valve morphologies. Thank you very much.
Thank you very much, Jörg. I'm glad that was recorded, because that was a masterpiece. I want to watch that again. I mean, this is so important what you've talked about there, because the challenge we really have with getting good data for tricuspid and also with choosing who we should be treating is how to separate them out. And if separating the different tricuspid phenotypes out involves 1,000 echo parameters, it's a bit of a challenge. Whereas you've given us a very simple rule for separating out atrial from non-atrial, which I think is really helpful. A question for you, and then we'll move on to the final part of this session, is if you are referred a patient who has severe TR, anatomical complexity that means that you can't be certain that you'll get them down to mild TR, they're not a candidate for surgery and they're not a candidate for tricuspid replacement. So complex anatomy, not completely sure whether you can get them down to mild. Should we or should we not be treating them?
Well, I would say in the majority of patients, of course, yes. It's always dependent I think that we take these information now into our account, that we're going to discuss it with the patient. What are the expectations of the patients, so that we can tell them, well, you still have like an 80% chance to get a good result, a symptomatic improvement, because we do know with TR of moderate or less, you get a symptomatic improvement at least. We don't know about if the patient is going to live longer, but we can incorporate these data to discuss it on an individual basis. If the patient has no other options, I would assume that the majority will tell us, give it a try.
Yeah,
because the procedure is so safe, and the risk for the individual patient that the outcome is worse than before is rather negligible.
Well, that's one of the key differentiators, isn't it? It's incredibly safe. The likely worst outcome is neutral. And you've lost nothing by trying, which I think is really important. So we've talked about the first two parts of our session today. So we've talked about grasping, we've talked about predictability, and the final chapter is versatility. So Niklas and Eiling are going to tell us a little bit about this. So we have a simulator and we have a case.
Yeah, thank you. It's a pleasure for me to be here, and I think we start with the simulator, and then then Eiling will present the case. And the colleagues from Edwards, they have prepared a very nice artificial heart simulator here, which is based actually, which is 3D printed and based on a human CT. And Isabella's going to support me with the echo. And the idea is to show you how really versatile the implant is, how nicely you can navigate through a tricuspid valve. And as a matter of time, we already have been steered down here to the tricuspid valve. We have a MPR reconstruction just for your orientation. I hope you can see it in the upper left in the green panel. You see the classic RV inflow. On the right side, the anterior side. On the left side, the posterior side. Then on the right side, in the red panel, you see our grasping or clasping view. On the left side, the shorter septal leaflet, and on the right side, the lateral leaflet, which is the anterior in this case. And then you see a reconstruction of the short axis on the lower left side, so the blue side, the blue panel. And so the components of the catheter, I think you're familiar with. So this is the guide sheath. It consists of 3 catheters. We have a steerable catheter, which we use to navigate either laterally or septally. And then we have the implant catheter, which carries the device, and we use this to bring the device forward and to change also the clocking. And then we have 3 different configurations. We can bring the device in. You see now the capture ready position with the open pedals. And we use this configuration to check how we communicate with our clasps. So we have a light gray pedal, which is usually the lateral leaflet, and we have a dark gray slider, which is usually the septal. So this is the case here. And so maybe we just simulate a grasping maneuver. I move a little bit more, maybe even anterior, but we are already quite anterior. And we already heard that we have 2 different options to cross the valve. One is to do it in the closed session. We will do this right now. And cross the valve here. Maybe we go a little bit more central, then it's a little bit easier. And now we can nicely cross the valve. It's important to really stay between the line of cooptation here, and then we open the device. Once we're doing that, you see that we usually move a little bit more towards the apex while opening. So we go a little bit higher. And then you may appreciate in the lower left panel, in the blue panel, in our short axis, maybe you can, that we're still able to rotate the device, which is very nice. And we can also push the device a little bit more anterior as we want. So there's really not so much interaction of the device with the leaflets. And then we go for grasping. So I think we pull everything a little bit up, and both leaflets are already on the pedals, don't you think? Yes, okay. And we have the opportunity to grasp or to clasp independently or simultaneously. We can do it simultaneous in this case. Usually we do it, in my practice, we do the same. We do it separately. But just for simulation, we grasp it simultaneous here, and then we close the device, and we see we have lots of tissue, I think, in there. We release a little bit of the tension, and then we assess our result. And the nice thing, I think, about the PASCAL system is when you're not happy with this, when you maybe think that another position for the device would be better, you can just let go of the leaflets and use the elongation configuration to free yourself from the leaflets and the interaction you had. So we elongate, and we just go out, and we pull a little bit towards the center of the valve, and now we're above the valve, and this is really unstressful, and you can go for another attempt, which is, I think, also very important in tricuspid cases.
It's a really important differentiator, this, isn't it? Because,
exactly.
I mean, for the TEER operators in the audience, it's a really unpleasant experience getting stuck under the valve. It feels uncomfortable, doesn't it?
Exactly.
And by elongating, the device has no sharp edges, essentially nothing to catch anything. And
yes.
In the tricuspid valve, there are lots of cords and often pacing leads as well. You need to know you can get out of trouble, and that's part of what makes it so safe.
Exactly, especially when we're very close to the commissure, very commissure. I think that's the narrow space. Yeah. And then you can go for another attempt, and I'll show you how you can also nicely cross the valve elongated, which we do right now. And then by getting back into capture ready, now you lose some height, so you have to anticipate that. So I go back into capture ready, like this, and then we move a little bit more to the lateral side. Maybe you can show the short axis again to check for the clocking.
So if we're looking at the bottom left-hand view now, to grasp anterior and septal, you usually want to be a kind of 2 and 8 orientation.
Yeah.
Something like that.
Yeah.
And mostly we grasp anterior septal first because you want to start far away from the imaging probe and move towards it just to minimize the shadowing with subsequent devices.
Exactly. So Isabella, what do you think about the clocking? I think I think it's fine. Yeah. Okay, so we go again maybe in the clasping view. And then we go for a separate clasping. I mean, both leaflets are
both are on, aren't they?
Pretty good on already, or engaged. But just to show you this, so we have the lateral, and then you can dive a little bit again into the ventricle and move to the septal side and pull up again. Just very slight maneuvers, and you can grasp or clasp the septal leaflet and close again. And I think what especially in tricuspid cases is a very useful tool or technique is to re-optimize or maybe to just reassess the leaflet insertion on the septal side. So you do not lose anything of the leaflet if you just open up the device again with clasps down.
Well, it's worth saying that if you do this and the leaflet falls out, you didn't have enough in the first place.
Exactly.
So better to establish that.
Exactly. And then you can open again the septal and see there is still a lot of tissue inside, or you can even move a little bit more to the septal side, clasp again, close again, and then release tension. Yeah, and as easy it is with the simulator, I must say it's in most of the cases as well in the patients, and really it's a very unstressful procedure without any friction.
Well, you make it look very unstressful. That was very impressive. So you had one of the most difficult things to do, which is to do a tricuspid case in front of a large audience on a model in 8 minutes. And I think that's pretty impressive. Thank you very much.
Thanks.
So we're going to wrap up now with Yiling is going to present us the final talk for this session.
So thank you very much. Delighted to be able to share some cases to bring us towards the close of this session. Hopefully I'll be able to show you 2 brief cases to illustrate the implant versatility that Nicholas has already demonstrated for us on the simulators. So our first patient is going to be treated for functional mitral regurgitation. This was an 83-year-old female with quite a lot of comorbidities, as you'll see listed there. Importantly, coronary artery disease with significant left main and LAD disease that was treated with angioplasty, complicated by intraprocedural VF requiring a period of CPR. This therefore meant she had a slightly protracted inpatient stay, had severe functional ischemic mitral regurgitation with moderate LV impairment, and the usual cardiac comorbidities that we see in our patients. She went into pulmonary edema, fast atrial fibrillation with an aspiration pneumonia, post-intervention, and therefore was persistently fluid overloaded and had a further peri-arrest episode on the ward. There was a possible GI bleed just to complicate an already multi-morbid situation, and you will see there that she had an anemia that was stable post-transfusion, some evidence of chronic kidney disease, and actually a BNP, not an NT-proBNP, that was significantly elevated at 2070. I'll show you some of her representative images, but just to highlight, there is a severe functional mitral regurgitation quantitatively, and I'll show you evidence of by leaflet tethering and some annular calcification that was not felt prohibitive. Regional wall motion abnormalities, as we expect, and there was also some evidence of right ventricular impairment and elevated pulmonary pressures. So in this clinical situation, this patient clearly was not deemed to be a surgical candidate, and given her clinical status following heart team discussion, there was consensus to offer her mitral TEER. This is her baseline transesophageal echo. You can see there appears to be quite a broad, largely central jet of functional mitral regurgitation, but this does extend medially. You can see the tethering, particularly of the posterior leaflet on the 3D on-fast images, and then color that sprays across the coaptation line. Importantly, sweeping through the tissue leaflet quality from medial to lateral along the bottom image panels, I think we can all appreciate whilst there is good leaflet length, the tethering, the pulling in of the leaflets does tend to lend an element to unpredictability in terms of the outcome that we might be able to achieve with edge to edge. So with that, I've already alluded to the challenges of a slightly broader jet, draws into some of the discussions we've had into choosing a single versus multiple implant strategy, being careful to achieve good leaflet grasp, but not taking too much in terms of tensioning that might be therefore imposed. So with the consensus for mitral TEER, we obviously undertook this with the Precision system, and given it was a fairly broad jet and the discussions we've already had, our strategy was we felt we would need more than one implant, and we therefore went with an ACE. Some may say try to approach the center of the jet to see whether actually how much reduction you might get, rather than trying to end up potentially chasing and propagating mitral regurgitation along the coaptation line in the case of ischemic functional MR. And so this is just to illustrate that with a slightly more central implant, you can see from the bottom color image panels and grasping views that we ended up splinting the jet with regurgitation both medially and lateral to that first implant. So with that in mind, we went ahead with what we thought would be the eventual strategy, so actually approaching much more medially than we thought we might need to. You can see good clasp leaflet capture there on the top image hand panel. And so with a fairly medial A3P3 deployment of the first implant, we certainly left no room medially for mitral regurgitation, and with a therefore lateral jet to treat. With that, we went ahead with a second implant, tucking it up to the first as closely as we can. You can appreciate the separate independent leaflet clasp function that we've talked about extensively during this session in action, allowing to optimize and making sure that we aren't actually encroaching upon the posterior mitral annular calcification you can see there in the top left image panel. We took care to align this implant to the first, and hopefully you will be in agreement in the bottom image panel that we achieved an excellent result for this patient with 2 ACE implants aligned and no residual mitral regurgitation that was clinically significant. We obviously pay close attention to the hemodynamics intraprocedurally, so we took severe, if not torrential mitral regurgitation down to no or trivial mitral regurgitation with a mean gradient of 2 across the valve. We don't always see a reduction in the left atrial pressures when treating functional pathology, but actually in this patient, her left atrial pressure reduced from a baseline V wave of 34 down to 22, and there was a corresponding reduction in the left atrial pressure from 23 to 18. You'll see on her 4-chamber images, on her transthoracic echoes there, pre and post procedurally, there's certainly quite a satisfying reduction in mitral regurgitation severity, corroborated by the fact that at 1-year follow-up, she remains in NYHA class 2 on optimal heart failure therapy, again with a sustained result out to 1 year with mild mitral regurgitation. With that, in the final few minutes, I'm going to move us swiftly on to illustrate a case for how we apply the PASCAL Precision system in treating a case with more complicated tricuspid regurgitation. Again, a very symptomatic patient, an 84-year-old male with NYHA class 3 breathlessness, persistent lower limb edema. He has torrential tricuspid regurgitation that I'll show you in the context of chronic atrial fibrillation. Comorbidities, as we would expect in an 84-year-old male, and importantly, this patient had multiple admissions with decompensated heart failure, was actually quite difficult to offload at his local hospital. You'll see from his medications list on the right-hand panel there that he required up to 1 gram of furosemide a day in order to achieve diuresis in combination with spironolactone and metolazone. His BNP was 217, and we find the TRI-score quite useful in our heart team discussions for trying to contextualize the preferred modality of treatment for this patient. His TRI-score was 6, so in line with that, a 22% predicted in-hospital mortality with isolated tricuspid valve surgery. In terms of the anatomy we've already heard about, he's got a slightly more complicated anatomy with a quadricuspid type 3B tricuspid valve, so bifid posterior leaflets, a large coaptation gap. This was predominantly atrial functional torrential regurgitation with low normal right ventricular function in the context of that volume overload, and importantly, no relevant significant left heart pathology that needed to be considered. So these are some representative transesophageal images, our working views in terms of the RV inflow-outflow views in the bottom image panel. I think everyone would agree there's pretty much TR across the entire coaptation line, spanning anteriorly to posteriorly, the complex anatomy type 3B that I've alluded to already, with a large central coaptation gap. So for us, in terms of determining and planning a strategy, this is certainly a patient we did not have the option of transcatheter tricuspid valve replacement at the time of treating him, although we now do. And given his relative frailty and what we've heard about safety of edge-to-edge from a tricuspid perspective, this was offered to him, bearing in mind the challenges of the coaptation gap, the complex anatomy. I think you'll see the prominent eustachian ridge that we might have to navigate across, and then the bottom right-hand image panel, prominent RV chordae, that where implant versatility again comes into play in terms of the elongation Nicholas has shown us. So just to show very briefly his leaflet anatomy from posterior to anterior with restricted septal leaflet that you can appreciate in all 4 views in the coaptation gap. And so with that in mind, we attempted to work between the anterior and septal leaflets along the most anterior aspect of the valve working posteriorly. Place the first implant using the Tarzan maneuver that you can see there that allows us to swing after achieving anterior leaflet capture towards the septal leaflet, which was restricted, as we mentioned. And then aligning the first in a 2-8 position, and then fairly swiftly tucking a second implant just posterior to the first, maintaining that same 2 to 8 o'clock orientation. Finally, with the third implant, we were able to actually reduce torrential tricuspid regurgitation down to probably mild plus, with a mean tricuspid valve gradient of 2, with unchanged right atrial pressures through what was a safe procedure requiring multiple elongations, as you can imagine. This gentleman is NYHA class 2 at 6 months post-procedure. Importantly, has had no further heart failure admissions, with stable echo findings as per the post-procedure. Thank you.
I mean, the anatomy in both of those cases was terrible. I mean, they're really, really great results. I mean, fantastic. That's the first case, not in any clinical trial, scenarios that we see all the time. You know, we see these patients on the intensive care unit, and illustrated really nicely that with functional MR, there's only so much you can do. You can either put it in the middle, you can put it on either side, and those are really the options for you. And you went very quickly from the middle, which wasn't so effective. You wouldn't have expected on the baseline imaging to close the medial commissure like that, but actually a result better than I could have ever imagined, actually. So great result.
Thank you.
So we're coming to the end of our session now. Thank you very much for joining us this time. Thanks to the excellent panel of experts behind me. Thanks to all of you for coming, and thanks to the Edwards team for putting all this together, which is a huge amount of work and done to a very high standard. So thank you very much.